This is my lovely patient Lauren, and we're going to do a filler demonstration on her lips today. So, Lauren, tell me, you've had filler before, correct?
Yes.
Okay. And you had your lips filled.
Yes.
So how long has it been?
It's probably been about 7 months.
Okay. And you feel like they're starting to go away and need a refluffing.
Absolutely. Yes.
Okay. All right. Okay, so we are going to use a product called Redensity as well as RHA2. Those are lower G prime hyaluronic acid fillers. Redensity is really nice because it'll leave a nice crisp edge, and I like it for the vermilion border. The RHA2 is going to be a little more robust and give us a little more volume in the vermilion body. So when you're looking at the lips, be careful and pay attention to the lip anatomy. So you ideally want a 1 to 1.6 ratio, the golden ratio. So your lower lip a little wider or thicker than your upper lip. Though nowadays things are changing, it's more socially acceptable to have a 1 to 1 ratio, but you never want your upper lip bigger than your lower lip. 1 to 1 is fine, but it starts looking a little crazy if it's a 2 to 1 or something like that. So you also want to pay attention to the lip tubercles. So in the lower lip, we have a tubercle on either side of the midline, this little mound or little fluff of tissue. And a lot of patients want it full all the way around, all the way down, and you lose that anatomical structure of the lower lip and it doesn't look natural. So I try to talk them into letting me do the tubercles. On the top lip, you have 3 tubercles under each cupid's bow and 1 in the center. You want to be very aware of the cupid's bow. That is the most striking feature of the upper lip. And your philtrum go from the tip of the cupid's bow up to the nose. She has a beautiful philtrum, but as we age, that flattens out and we lose that definition. So it can be really nice on an older patient to rebuild that philtrum. Just remember, it's not a straight up and down, it's more of a V shape. They angle in towards the nose. It can be a very ouchy injection, closer to the midline, closer to the nose. So with lips, I do like to do a nerve block, but many patients don't want to be numb. It's like going to the dentist, you get numb and you're numb for a few hours and they'll talk like that for a few hours after your appointment, and it's kind of annoying. I think it's better than feeling the pain personally. So, but a topical numbing usually does the trick, and I think a vast majority of my patients, would you agree, do the topical?
Yes.
Yeah, okay. But we're going to demonstrate the nerve block so you can see it, and so Lauren here is nice and comfortable and doesn't kick me during the treatment. Okay, so have you had any blood thinning medicines recently?
No.
Any red wine, alcohol recently?
No.
Okay. I just ask because sometimes you'll bleed more. Okay. And bleeding's not a big deal. It can happen. It'll go away. If there's a big old bruise, we have a laser that we can use to break up the hemoglobin, so we can see and laser it, and it'll go away faster.
Okay.
All right. So for a nerve block, now my dentist actually taught me to do this. I didn't learn this in med school. The nerve block for the lips is the infraorbital nerve on the top lip and the mental nerve on the lower lip. So if you think about the skull and you think about the face where the nerves are coming out, you have your supraorbital nerve bundle, your infraorbital nerve bundle, and your mental nerve bundle, the artery, vein, and nerve. And they're all in a kind of a nice little line here. It's really, really pretty the way we were designed. So if you think of that, you can use that as your guide. But I like to use the teeth as my guideline. And we had like a 20-minute lecture on teeth in the first year of med school. I don't remember what they're called. We're supposed to be able to call the dentist and talk to them knowledgeably, like we know what teeth we're talking about. I just count teeth over, and I always have. So you'll hear me counting 1, 2, 3, 4. But on the top, it's easy because it's the canine tooth is your landmark. So we have a little bit of mucous membrane lidocaine here. I'm going to open her mouth and find that canine tooth. Hers isn't as defined as the others. Some people have real nice sharp ones. You know that's their canine. But it's the 3rd tooth over, and you go up and put your numbing right up in the sulcus there. Okay, so you're in line where that infraorbital nerve, artery, and vein is coming out. Same thing on the other side. And you just let that sit there. We call this the walrus stage. And then on the bottom, we do the reverse walrus. So we're going to use 2% lidocaine with epi. So prep my needle. Okay, so go ahead and take those out. I'm going to have you turn towards me. Okay. Open slightly for me. So I'm going to grab her lip, lift it up. 1, 2, 3, inject. Inject till I hit the periosteum. Pull back a little bit. Inject, shake that lip because it helps confuse the brain. Brain's like, what's going on here? Why is that shaking? Usually about 0.75. We're done. You okay?
Yeah.
Okay. I'm going to do the same thing on the other side. Put it a little bit away from me. 1, 2, 3, stick. And sting. Sting, sting, sting. Okay, so this all doesn't taste very good. Do you need to spit? Have the little Kleenex. It just tastes nasty. Even the mucous membrane lidocaine, they put a spearmint flavor in there, and it's just gross. Okay, now we're going to do the reverse walrus. This is where I have to start counting teeth. So 4.5 teeth from midline is the way I remember it. So I think it's the premolar and the first, between the premolar and the first molar, but that's, don't ask me for sure. Okay, so we go midline. 1, 2, 3, 4, halfway back, down into the sulcus there. Boom. Same thing. Midline, 1, 2, 3, 4.5. Boom. Hold it there for about 30 seconds. Lauren, is your top starting to feel numb?
Uh-huh.
Yeah. Sometimes the tip of the nose will get numb. Sometimes, depending on how that neurovascular bundle branches, sometimes the cheek and the lower eyelid will get a little bit numb. That's all normal. Warn your patient, their eyelid might start twitching and they freak out. Tell them that's all normal. It's just the way the nerve branches. We're getting it at its base where it's coming out of the skull, and it's branching and going in all sorts of directions there. Okay, take that down. Okay, turn towards me, and actually tilt your chin down a little bit. Yeah, okay. I got to count again. 1, 2, 3, 4.5. 1, 2, 3, stick. And sting. Down here, usually 0.5 does it. Okay, you okay?
Mm-hmm.
Okay. And I'm going to come around on the other side. One, 2, 3. And sting. Okay, now if I calculated right, I should have just a little bit left because that nerve block gets the sides really well at the top lip, but sometimes it doesn't get the center. Usually the bottom gets numb all the way across, but do you feel like you're numb in the center or not? No? Okay, so I'm going to put one more right in the center, okay? This will make the tip of your nose feel numb. Go right on either side there. It's a stingy one, sorry. Okay. You need to spit again? Okay, now, the disadvantage with a nerve block is she's going to lose some muscular tone too, so that can alter things a little bit. Can you purse for me? Yeah, so you can tell it's already taken effect because you can't purse. Do a little Hibiclens, keep the skin as clean as possible. Okay, you think your top's numb enough to start? Okay, all right. Okay, so we're going to use that real low G prime, the RHA Redensity in that border. And Gwen has gone ahead and split me in half so I could have a nice fresh needle for the other side. Okay, so I'll turn a little bit. Now I want to get out to the corner. Tilt up for me. We're going to try to go right at that edge. 1, 2, 3, stick. Good. And with Redensity, it doesn't retain a lot of water. You can be very, very superficial. And it'll give a nice crisp edge so you can see where my needle is. And we're just going to do a retrograde injection. Good. And then massage as we go. How you doing?
Good.
Okay. 1, 2, 3. Okay. Now, I like to have the patient sit up because I want to see them with gravity doing its worst. And if you look, you can just see it's just starting slightly, just getting a little more definition. All right, let's go on the other side. How you doing? Okay. So I make my patients do a lot of abs, up, down, up, down. 1, 2, 3, stick. You can see how superficial I am with my needle. Most HAs, you couldn't be that superficial. You'd get some tindling, get too poofy. How are you doing? Did you feel that in the center a little bit?
Mm-mm.
Okay. Okay, now on this side, my second injection, I could see it travel in that white roll all the way down on my Cupid's bow, but it didn't on the other side. So I need to get a little bit in that leg. And since we did that center injection for the numbing, I'm confident she'll be good for pain-wise. 1, 2, 3. That's a really ouchy one if they're not numb. That center one. Okay, very good. Okay, now we're going to line the bottom. We got a drop in here. All right, turn towards me. One, two, three, stick. Here's my needle. And lift up and see it. Okay, come straight on. I'm kind of feeling where my product is, so I know where it ends, so I know where my needle has to reach for my next injection point. Okay, and then I'm going to come back and get that last bit from your side. Okay, now, so I got the lip outline done. Come forward again. Okay, so. Now she's numb, so she doesn't have the muscular control. So that can throw the eye, but I feel like you can see I need a little more in this peak and a little more in the body on this leg of the upper lip. I like the bottom. We could define those tubercles a little bit more, and I always get another pair of eyes. What do you think, Winnie? If you've noticed, just by doing some support too in the lip, those commissures have come up a little bit. So we've just naturally helped that area by revolumizing the lip border. But yeah, we need to get like right there. Okay, come on, you're back on this side. Okay, so I'm gonna go kind of at the wet dry border this time. So I'm gonna stay very superficial under the mucosa but over the muscle. And just get a little volume there. Kind of want to do the same thing on the other side. Do-si-do. Okay. Let the wet dry border again. Very superficial. Some younger patients like the low G prime, very superficial just for hydration. They call it internal lip gloss. So that seems to be a popular thing trending. But RHA1 or Redensity is a great one to use for that. Okay, now, well, I'm gonna have you look. You tell me if you like it, if you want more volume.
I think a little more
On those sides.
on the side.
Okay.
Would be good.
Okay.
Thank you so much.
Yeah, no problem. Okay, so this is a tough one to do because especially in Caucasians, we lose lip volume. We don't have a lot to begin with, and that those sides collapse. And it can be very hard to reestablish those, especially if they were never really there to begin with. So my rule of thumb for that is we'll get some, but it won't be huge. We'll get some improvement. What I like to do, I think of them like little pillars in the lip. So I'm going to start on this side, so turn towards me. So I will start at the wet dry border, go up to the vermilion border, and do pillars like fence posts. The other way to do it is have the patient lay back, come in from the vermilion border, and leave your deposit at the wet dry border, and then come up into your fence posts that way. But for this setting, we will do starting in the wet dry border. And we're gonna kind of roll the lip over the needle till you get it right in that border. I've already done the border, so I don't want a whole bunch there, but I'm gonna inject as I come out. And get a little bit of a lift in that corner. And so we're just gonna do a few of those. 1, 2, 3. Kind of roll the lip over, staying out of the muscle. There we go. There, get it close. Yeah. Yeah. Okay. Other side. That was our worst side. I don't think she needs quite as much on this side. I may only do 1 or 2 pillars. What did I do? 3 on that first side? 1, 2, 3 stick. Okay, forward again. I still need to get this peak a little bit. And then I just want to fluff those lower tubercles, and I think we're going to be good. Okay. Yeah, one more time. Rotate. Give you that. Okay. Are you feeling any of this?
Nope.
Okay. I want one more pillar on this side. Okay. All right. One more time. Okay, Gwenny, what do you see?
It needs to go up a little higher on that peak.
That peak?
Yeah.
Okay, one more drop over there. Yeah, I think you're right. Do you think here?
Maybe towards the leg.
Yeah, on the lower.
Yeah.
Yeah, okay. Okay. Last little inspection, we're going to fine tune, and then we're going to be done. Now, I'm going to warn her, the lips swell a ton. She's already starting to swell, but it's going to swell a lot more over the next 12 hours, especially if she goes and sleeps flat and wakes up in the morning. They're going to be scary swollen in the morning. So I always try to warn your patient about that.
Lauren also said that her lips were a little chapped and said they might be more chapped.
Yes, that's true too. So now, since we're filling the area, we're exposing a little more pink to the air. Winter's coming, you know, they're going to get more chapped more easily. So make sure that they have a good lip product. Keep those luscious lips moist. Turn towards me. And then with all my filler patients, I like to give it a couple weeks to settle down, let all the swelling absorb, let the product settle in, and then bring them back for what I call a tweaking. And I tell them to make an appointment for 2 weeks, 2 to 4 weeks. If they love it, they can call and cancel it. But if they need a tweaking, we got the time set aside. And I usually don't charge for a tweak as long as it's 0.2 or less of filler. But you have to, in your own practice, establish how you're going to handle that. Sometimes we'll reserve a little bit of filler. Once you open the filler, you got about 6 weeks to use it. And Gwen's very good about that. She goes through her dates and about once a week and throws out any filler that's older than 6 weeks, because the studies show that once you open it, the risk of contamination goes up after about 45 days. This is just a little arnica. And I'm massaging, but I'm also feeling to see if I have any gaps. Feels pretty good, pretty good. Now I tacked your upper lip a lot more, so it's going to be more swollen, okay? So it'll settle down. But right now it's more of a 50-50 proportion, but it'll calm down. Okay, all right. And we'll have the patient sit up and take a look. Make sure she's happy.
Mm-hmm.
We have more if you want to tweak anywhere.
Can I get a little more, like right here?
Yeah, absolutely. I see what you're talking about. Okay, so she's looking at, so here's the tubercle on the upper lip. It's just drops off a little too suddenly compared to the other side. So we're just gonna, we call it very scientifically a gnat's ass of filler. Right there, and smooth that edge of that tubercle. Okay, very good. All right, yay.
Thank you. Can't feel
Okay,
anything.
so a little ice tonight. Try to sleep with an extra pillow just so there's less swelling. Don't panic when you wake up in the morning. It's going to be the worst. And then over the next few days, the morning is going to be worse, and then the day goes by, the swelling will go down. And then we'll check in 2 to 4 weeks. Okay?
Okay.
All right, very
Thank
good.
you so much.
Thank you. If any of you want to spend some time with me one-on-one learning and filler injections, feel free to call us, or contact us at info@medicalaestheticsacademy.org, and we'll be sure to get back to you. Thank you.
For additional information and hands-on training, please email info@medicalaestheticsacademy.org or call 314-586-0642.